Very good. All right. I think we have enough to go ahead. My name is Mohammed Mamdani. I'd like to welcome everyone here to our TCARM speaker series, which we're really excited about. Just as a quick background, the Temerty Center for AI Research and Education in Medicine at the University of Toronto, or TCARM, has been made possible by the generous donation of the Temerty family. TCARM is an interdepartmental center that serves as a focal point for collaboration between healthcare providers, trainees, researchers, computer scientists, engineers, and industry to advance health through artificial intelligence. Our goal is to transform healthcare through AI. I also want to mention that this event is CPD accredited. So in order to obtain your CPD credit, please complete the evaluation form, which will be emailed to all attendees following the event, and provide your name and email address in the evaluation form. And you may hear a dog in the background. I apologize, I'm at home. A note to the attendees, please use the Q&A function in the Zoom window to submit your questions for Dr. Celi. Dr. Celi will address them during the discussion portion of this webinar. And at this point, I'd finally like to get on to the introduction of Dr. Celi. We're incredibly fortunate to have Dr. Celi speak with us today. Just as a brief bio, Dr. Celi is a clinical research director and principal research scientist at the MIT Laboratory for Computational Physiology, or LCP. He's a practicing intensive care unit, or ICU, physician at the Beth Israel Deaconess Medical Center. And he brings together clinicians and data scientists to support research using data routinely collected in the process of care. So not only understanding the mechanics of AI and machine learning and such, but I think the far greater role of how do you get people together to create effective solutions and actually use them in clinical practice. His group built and maintains the publicly available medical information mart for intensive care database known as MIMIC. And I have to highlight this because MIMIC is among the most widely used data sets in the world for research. And I know our computer science community here relies on MIMIC quite a bit in healthcare to do research. So thank you, Dr. Celi, for your incredible contribution to the research community. But also he built and maintains the Philips MIT eICU collaborative research database with more than 15,000 users from around the world. In addition, Dr. Celi is course director for 2 courses at MIT, Global Health Informatics to Improve Quality of Care, and a second course, Collaborative Data Science in Medicine. He's an editor of the textbook for each course, both released under an open access license. The textbook Secondary Analysis of Electronic Health Records has been downloaded more than 940,000 times and has been translated into Mandarin, Spanish, and Korean. Again, incredible contributions to the research community. Dr. Celi has spoken in more than 35 countries and apparently is going to be traveling to 10 more this year across 6 continents about the value of data and learning in health systems. Dr. Celi, it's my privilege and honor to welcome you to the TCARM community and really thank you for sharing your knowledge and your time with us. Thank you.
Thanks, Mohammed. Please call me Leo. I just finished a 9-day stretch in intensive care unit, so forgive me if I fall asleep in the middle of my talk. I think I can have Alistair ring me if I fall asleep, but it's a pleasure to be here. As Mohammed mentioned, I still practice medicine in intensive care unit, and but the research is based at MIT. Alistair is one of the faculty there now, is the chief architect actually of the 3rd and 4th iteration of the MIMIC database. So a shout out to Alistair. Can we go to the slides, please? And next, please. The next slide is just a disclosure of financial support for the center. Next, please. And our group at MIT receives funding from the following industry partners: as well as the National Institute of Health. Next, please. These are the objectives of the speaker series. I'll give you a few seconds to go over that. I suspect that you've seen this in previous speakers' presentations. So we're going to be quick. And then next, please. And these are my objectives. And I'll give you maybe a bit longer time to just have a look at what I'm hoping you will be able to take home after the end of this talk. With a focus on the third, I hope that this would inspire you to really do something because your health is at stake. And next, please. So I represent MIT Critical Data, which is a global consortium consisting of healthcare providers and public health practitioners, as well as computer scientists, other data scientists, social scientists. And the mission and the vision is to put data and learning at the front and center of healthcare. We think that data and learning are actually the best medicine for population health. We build communities across disciplines to leverage data routinely collected in the process of care in order to understand health and disease better and in the local context. Next, please. You've heard about our flagship projects. The first one is MIMIC, which is short for Medical Information Mart for Intensive Care. It's a repository of data collected from patients admitted to all the intensive care units of Beth Israel Deaconess Medical Center. The fourth iteration of MIMIC is now available. That data spans through up to 2019, and it's no longer just limited to the intensive care unit. For the first time, it will contain data coming from the emergency department, including those patients who were not admitted to the hospital. But for those who got admitted to the intensive care unit, that is critical information to understand what sort of treatments were given in the emergency department, even prior to arriving at the ICU. Our other big, the other big change with Mimic 4 is that it includes the actual images. So not just the radiology reports. So Mimic 4 contains about 350,000 chest x-rays that are linked to the electronic health records. So now you have some automated way of labeling. You're no longer just depending on the radiologist's report. You could label these chest x-rays with actual outcomes as documented in the electronic health record. So I think this will open a new avenue of research in computer vision, in creating fusion models that will include both images with their millions of pixels, as well as clinical data. The other big data set is the EICU Collaborative Research Database, which is data collected from the telehealth platform of Philips, the EICU. And this data comes from more than 200 hospitals across the United States with a little over 200,000 ICU admissions. So the advantage of this is that you can cross-validate the models to see whether the models are accurate across different settings, across different hospitals. But the challenge there is that the data is going to be noisier because there are differences in the way data is being collected in different ICUs. Next, please. But data is not enough. Data sharing is not enough. Um, we compared data, raw data, as being like crude oil. It needs to be refined. You can't just go in there and start building models on Mimic. Curation is much, much harder than the data analysis part. And when I mean what I I'm referring to when I talk about curation is how concepts are defined, how patients are identified. And I think our biggest contribution, in addition to the data, is actually having a publicly available repository where codes are shared and can be reused. And this really promotes or accelerates research because you could build upon the research that has been published using these two data sets. And it really creates this ecosystem that is a bit more collaborative compared to how research is being performed in the previous centuries, where people are holding on to their data, they're not sharing it, there's no way of validating their results. And as you've heard, reproducibility is a big concern. So by sharing the data and sharing your GitHub and your Jupyter notebook and your Colab, you're really hopefully promoting reproducibility. I think there will be less temptation to keep running your models until you find a test set that will give you excellent numbers if you know that someone else will try to replicate your finding so that they could carry on the research that you have started. Next, please. We are not invested in just providing the data resource. We're also invested in training the next generation of clinicians. So not just doctors, but definitely the pharmacists, the nurses, the other allied health professionals who are involved in the provision of care, as well as the computer scientists and the engineers. And increasingly, we have been bringing the social scientists because healthcare is not just a medical problem. The social determinants are definitely drivers of outcomes. So we need to have a social science perspective as well when we perform the modeling using the data. So as mentioned, we have this textbook that was published in 2016, and hopefully we can translate this to even more languages so that we could reach more people around the globe. Next, please. We teach a course at MIT called HST 953, Collaborative Data Science in Medicine. It accompanies the textbook, and projects from the course have actually been published in relatively good journals such as Nature Digital Medicine, Lancet Digital Health. An online version under edX was premiered last November, and we're hoping to rerun the course hopefully in 4 weeks' time. So this is a collection of the workshops, of the exercises that we have recorded over the last 4 years and are sharing with our colleagues from around the world. Next, please. We have another course and textbook. We're actually teaching that course right now. It's called Global Health Informatics to Improve Quality of Care. The focus has been on the design, evaluation, and implementation of health information systems. And the textbook is published under an open access license by MIT Press. For this spring, we decided to focus on COVID-19 and the analysis of COVID-19 related data. So we're trying to put together an edX course as well so that we could share lessons learned, best practices, and hopefully improve preparedness for outbreaks and disasters in the future. Next, please. An online version of the course has been available at no cost on edX for several years now. And next. And we're happy to announce the publication of our third textbook. It was released last summer. It's called Leveraging Data Science for Global Health, and with funding from MIT libraries, the digital copy of the book is also available for free. The most daunting challenges right now are interconnected. Uh, Global warming, the pandemic, structural inequities. In this book, we highlight the need for a multidisciplinary approach to data science. Data and learning should also be at the centerpiece of global health. Every patient encounter is an opportunity that we could learn from, And every healthcare provider should be a contributor and a custodian and not merely a passive recipient of the medical knowledge system. Next, please. The most fun part of what we do is this Datathon. So Datathon is short for data hackathons. We've organized 37 of them in 16 countries across 5 continents. And during these events, we bring together clinicians, computer scientists, engineers, social scientists, and over typically a weekend, they work on a specific clinical question pitched by a medical student or a computer scientist or a nurse or a doctor. And over that weekend, we bring mentors who can help the teams navigate through this very complex databases and, of course, make use of the reusable codes that are found in the respective repositories. These events are also meant to bring in the different stakeholders, so not just academia, but we make sure that we reach out to the health ministries when we go to other countries, as well as industry partners, because we feel that the partnership across this 3 domains is needed to be able to advance the field of machine learning as applied to healthcare. The other strategy that we have adopted is really building these regional hubs or regional networks. So our team cannot work with each country because we don't have the bandwidth. But what we're doing is we're connecting the dots. What we've realized is that there are already pockets of expertise that exist in every country, and it's a matter of linking them so that they could take each other's expertise and really take advantage of what they could bring to the field. Next, please. And these are just some of the photos of our events. I believe we've had 2 datathons in Toronto, so we look forward to the third one. And what we also try to do is to bring the people who have attended this events so that they could become mentors to future datathons in another part of the world. Next, please. Okay, 2021 marks the 10-year anniversary of IBM Watson beating humans in the game show Jeopardy! The event is considered as as heralding the age of artificial intelligence, and data scientists set their eyes on healthcare, a $1 trillion industry that is saddled by inefficiencies, waste, medical errors, and uncertainties. Next, please. But a decade later, reality has fallen short of the promise of AI in healthcare. IBM is now exploring the sale of Watson Health, a unit whose product was supposed to assist doctors in diagnosing and curing cancer. Next, please. 2021 is also the 5-year anniversary of Google DeepMind beating the world champion on the board game Go. Next, please. And just like IBM, Google DeepMind has lost money in recent years. Next, please. The stumbles highlight the challenges of attempting to apply AI in treating complex problems. And to quote the American journalist H.L. Mencken, every complex problem has a solution which is simple, direct, plausible, and wrong. Next, please. Which brings us to the application of AI in healthcare. But before that, I wanted to share a very personal anecdote that showcases challenges in clinical decision making. I was working 5 years ago, and I remember the date because it was Valentine's Day. And I received this phone call from an outside hospital. They said that they wanted to transfer this patient for consideration for ECMO, or extracorporeal membrane oxygenation. That means that the lungs are not working at all despite connecting the patient to a breathing machine. And this is the most invasive of all interventions that we provide in the intensive care unit, where we draw the blood from the patient, we artificially oxygenate the blood, and then bring it back to the patient. And they said that the patient likely had a drug overdose and right now is on 100% oxygen and is not doing well. So we better consider um, connecting the patient to this ECMO machine. So I called the ECMO team, uh, triggered the panic button so that everyone comes in and get ready to receive the patient. We received the patient 3 hours after. It was a young Black gentleman, but by the time we got him 3 hours later, the diagnosis was obvious. He was covered with this rash that was pathognomonic of a very fatal bloodstream infection where the only possibility of survival is early administration of antibiotics. He had what we call meningococcemia. And it didn't enter the minds of those who, um, who saw him in the emergency department at the outside hospital because they saw this young Black male who was found unresponsive. And the first thing that came to mind was drug overdose. And of course, hindsight is 2020. I probably would have made the same mistake. And we were wondering whether a computer would have said, look at these numbers. Um, should you be thinking of sepsis from meningococcemia? But again, there's so much recall bias that happens. What you do is you ignore the numbers that are not consistent with your diagnosis and you focus on the ones that support your impression of the patient. So those are sort of the problems that are quite common in medicine. And those are the sort of problems that we're hoping to fix by providing decision support tools to clinicians at the point of care. Next, please. So going back to medical algorithms, I would like to direct the audience to this report that was published just at the start of the year. It's from the FDA, and it presents how the FDA is considering the regulation of AI as a medical software. It's not that long, so as I said, I recommend that you read this before you go to bed. Next, please. As of a year ago, the FDA has cleared 64 AI-based software in healthcare. And unfortunately, none of these 64 AI-based software in healthcare has demonstrated benefit in terms of patient or health systems outcomes. Next, please. By far, the most common algorithm in healthcare is mortality prediction. The approach is straightforward. There is a set of features pertaining to the patient and to the disease mapped to the outcome, such as survival. And the machine learns the associations between the features and the label. Looking at this graph, note that there is a big jump in mortality prediction papers published last year. Any guesses why? I'm sure the answer is obvious. Next, please. The pandemic definitely solicited even more mortality prediction papers over the last year. This is an interesting issue of the New York Times from more than 100 years ago. This one is from September 14, 1918. And there was an article that quoted the Surgeon General at that time, Dr. Rupert Blue. He was saying that, oh, the doctors in other countries have started using this anti-malarial drug called quinine to treat the pandemic. And there was no evidence that the anti-malarial drug quinine works, but the doctors were desperate. They were willing to try anything, and so they did. Um, eventually, they would abandon the use of the anti-malarial drug quinine when studies showed that it was not only ineffective, but it was also potentially um, had adverse side effects and even fatal in some cases. So how times have changed over the last 100 years. Next, please. At the start of the pandemic, states and professional societies scrambled to put together guidelines in the allocation of scarce resources, such as the breathing machine or a ventilator. Ventilator allocation guidelines were developed by at least 26 states in the United States, and 21 of those suggested the use of the sequential organ function failure assessment or SOFA score as an objective scoring system. For example, the states of Michigan, Minnesota, New York, and Washington recommended that a SOFA score of more than 12 should trigger a discussion of whether it is appropriate to admit the patient to the intensive care unit or to continue the treatment if the patient is already in the intensive care unit because of a high likelihood of death. And while clinicians and policymakers may find solace in the apparently objective nature of prediction models during decision-making process, they may be oblivious to the underlying inherent biases that lurk in these scoring systems, resulting in widening disparity in the delivery of care. Next, please. With that in mind, our team examined the performance of three illness severity scores, namely Apache 4A, SOFA, and OASIS in the two large publicly available ICU databases that we have, MIMIC 3 and EICU CRD. And next, please. We're happy to report that the discrimination of Apache 4A, OASIS, and SOFA was similar across the ethnicities, and we investigated whites, blacks, Hispanics, and Asians. Next, please. However, with regard to calibration, the three scores over predicted mortality in all ethnic groups. This table or this figure shows the standardized mortality ratio. So that is the ratio of the actual death compared to the number of predicted death. The poor calibration was particularly notable among the Blacks and Hispanics. There was a statistically significant difference in the standardized mortality ratios of whites and Blacks for both Apache 4A and OASIS, and a statistically significant difference between whites and Hispanics for OASIS. Next, please. We observed the same over prediction of death among Blacks and Hispanics based on SOFA in both EICU CRD and MIMIC 3. Accurate calibration is particularly important if we are going to use these illness severity scores for decision making. Triage decisions related to admission to, management in the ICU, as well as discharge from the ICU, are potentially subjective and vulnerable to bias. Scoring systems may be applied to these decisions in order to introduce a greater level of objectivity and fairness when resources are critically limited. However, if the systems themselves are biased, then their use for these purposes only introduces an even greater level of unfairness. Next, please. Last year, there was a commercial algorithm affecting millions of Americans that was shown to exhibit racial bias, dramatically underestimating the health needs of Black patients. Trained using healthcare costs as the proxy for the need for more comprehensive care, the algorithm was designed specifically to exclude race as a feature in order to avoid bias. But cost is clearly not a race neutral measure of healthcare need. Studies have repeatedly shown that Blacks receive less preventive care as compared to whites. And with this algorithm, Black patients were less likely to be flagged or identified as requiring complex care in the future. Next, please. This is why news like this are extremely worrisome. As early as April last year, dozens of hospitals across the country adopted an AI system created by Epic to predict the trajectory of patients admitted with COVID to the hospital, even as many were struggling to validate the tool's effectiveness on those with the new disease. Were the algorithms evaluated and recalibrated using local data? Were the algorithms interrogated for bias? And is the performance of the algorithms continuously tracked after deployment and periodically recalibrated? Next, please. This algorithm for predicting clinical deterioration from COVID was granted a patent by the FDA in May of 2020. A close scrutiny of the performance, as reported by the company, shows a precision or a positive predictive value less than 5% for respiratory failure and with a lead-in time of 4 hours. The precision or the positive predictive value is slightly better for the prediction of hypotension, but with the same lead-in time. As a clinician, I couldn't see any value of being able to predict whether a patient is going to need a ventilator 4 hours from now if it's only accurate in 5% of the time. And yet, this application for a patent got approved. Next, please. And even more importantly, majority of the algorithms are being trained and validated on data coming from only a handful of countries, further reinforcing the tradition of a medical knowledge system that feeds into health inequities. We need a better roadmap to leverage the value of machine learning and derive knowledge from the zettabytes of health data that we collect in the process of care. Next, please. Let's go back to how machine learning works. Just a review again for outcome prediction. There's a set of features related to the patient and the disease that is mapped to a label. The machine learning learns the associations within the data and is able to predict an outcome given a set of features. That's easy and straightforward. But when we do this, there is an implicit assumption that treatment decisions are the same across similar patients, but they are not. These are two papers from our group demonstrating outcomes for sepsis varying across hospitals. Next, please. And there's more to complicate matters. These papers shown here demonstrate that gender and race discordance between the provider and the patients lead to worse outcomes. For those in this exciting field of medical artificial intelligence, we need to remind ourselves that the data we are using, the data that is collected in the process of care, are heavily influenced by long-standing societal, cultural, and institutional biases, as well as provider subjectivity in decision-making. So before you even start exploring the data and building your models, you have to look into how the data was put together. You have to make sure that there is no selection bias that led to the inclusion of a patient in a certain database. So I wanted to explain further. Next, please. So going back to machine learning predicting mortality using real world data, as I said, it will reflect societal biases around which lives are worth saving. And it could potentially perpetuate or even magnify health disparities. To break the cycle, what we would like to do is to predict an outcome if the world were fair, and if access to care is the same across populations. As an analogy, let's consider a bank loan algorithm. The ideal data set to build this algorithm is where everyone gets a loan and everyone has equal opportunity to repay that loan. But those data sets do not exist. The data sets that we build bank algorithms are data sets where we've excluded a lot of clients whose loans were declined and who were not even given an opportunity to repay the loan if the loan had been granted. That is the counterfactual data set. And that is the data set that you would like to build if you want to fix the world. Next, please. And depending on the proportions of different groups in the real world data set, as I alluded to earlier, false associations between upstream features might be forged, otherwise known as collider bias. This is my favorite topic at present. This collider biases will be reflected in the prediction algorithm. The paper I show here, which was published just recently in January of this year, has through the roof altmetric. You could see an altmetric of 1,323. And the paper looked at the drivers of outcomes from COVID among veterans who were admitted to the Veterans Administration system. Next, please. These are their main findings. This is a table of the multivariate regression model looking at what are the predictors of hospital mortality, ICU mortality among those veterans who were admitted to the hospital. And it shows nicely that increasing age is a risk factor for death. There's no surprise there, but what was surprising was smoking and obesity were protective. Those who were smoking, either currently or previously, and those who were obese were less likely to die from COVID. I've been taking care of patients in the ICU with COVID for the last year, and I do not agree with that. A lot of the patients who were admitted to the ICU were definitely prior smokers and were definitely obese. They had worse trajectory of the disease. But what happened here? If you're to use this data to build a mortality prediction, it's going to say that if you're a smoker and if you're obese, you are likely to survive. What happens here is that there were so many more smokers than non-smokers who were veterans who got admitted to the hospital. And also the obese patients who were veterans were more likely to be admitted to the hospital than an equally sick non-obese patient. So there's a selection bias of who got into the cohort. And because of that, all these spurious associations were learned by the machine. And if you're to believe this, then you're gonna be developing flawed models. As soon as you build this model and go somewhere else, your predictions are going to be inaccurate. So again, I would like to warn the people who are interested in this field, before you even do the modeling, you have to know how the patients got into the data set. So that's very true when you're looking at transplant data sets. How are people evaluated for transplant? Are there biases lurking there that could affect the proportion of different populations in the transplant cohort? Because the models that you build using those data sets will reflect the collider biases that are ingrained into those data. Next, please. Which takes us to the myth of generalizability. We should really move away from a business model where medical algorithms are being sold and bought. The business model should be around assisting healthcare organizations to build their own algorithms, to deploy them, to pilot them, to scale them, and to continuously track and recalibrate them. As we discussed in this recent commentary, generalizability of medical algorithms is a myth. Even when it exists, it is transient. AI requires continuous evaluation and recalibration. Next, please. Which brings to the question, who will make sure medical AI will not and does not contribute to health disparities? Next, please. Let's digress for a moment. Go back to pre-COVID times, 2019. There was a hugely popular app at that time that transformed face photos into a preview of what one would look like in the future. The app, as we would later discover, came from a Russian company, which in the process amassed millions of face photos that could easily be linked with other data. Next, please. And how can these face photos be used? Here are some examples. With access to images of thousands of unknowing New Yorkers collected by the New York Police Department through surveillance cameras, IBM created an algorithm to search camera footage for images of people according to their skin color. And using Amazon's face recognition app, police in Oregon saw their investigative powers supercharged, allowing them to scan for matches of a suspect's face across hundreds of thousands of mugshots in no time. Next, please. Companies like Microsoft, Dell, and Concur sold algorithms to the US Immigration and Customs Enforcement during the Trump administration to improve its search function. Next, please. And the questionable use of data in AI is not restricted to the large companies. Clearwater AI is one of several startups that also offer face recognition software. It scrapes the internet for photos to build its large database of images. And the software has been used by law enforcement agencies, including the Department of Homeland Defense. And just like a search engine, you could upload a photo of an unidentified person, and the software would return other photos of the person on the web and links to where the photos come from. And of note, none of the face recognition software was vetted by an independent party before they were used. Next, please. In 2017, an anonymous Redditor with the username of Deepfakes released a software toolkit that allows anyone to make synthetic videos in which a neural network substitutes one person's face with another's. And along with the kit, the user posted pornographic videos known as deepfakes that appeared to feature Hollywood actresses. In the video referenced in this paper, Obama seems to say, "President Trump is a total and complete dipshit. How we move forward in the age of information will determine whether we become some kind of fucked up dystopia." Next, please. And in natural language processing, text synthesis software could theoretically be used to generate fake news or comments. So when you're working on building a health algorithm, a medical algorithm for decision support, you have to start thinking, how could this algorithm contribute to health disparities? And not just be focused on the accuracy, the discrimination, the calibration, the precision, and the recall. Is there a possibility that this algorithm could actually widen the inequities that currently exist in the healthcare domain? Next, please. There is no monopoly on AI. Companies peddling AI will continue to flourish because there is so much money at stake. Next, please. We need legislation that mandates transparency in the way organizations are using sensitive data, whether it's health related or not. Laws need to be passed that prohibit commercial use of identifiable data, including GPS location, images, social media, and internet use. Laws need to be passed to prohibit the use of health related data outside of research that does not benefit patients. Next, please. And finally, this shows the life cycle of artificial intelligence. Everyone is so excited about the middle step, but I could tell you that machine learning is the easiest of the three. What comes before, the creation and curation of data, and what comes after, bringing the algorithms to the bedside and to the policymakers, are so much more difficult. We need more investments on the data infrastructure and on the implementation science rather than on the AI itself. And with that, I open the floor to questions. Thank you.
Great. Thank you so much, Leo. That was a fantastic talk. We have questions, quite a few of them that have come up, which is fantastic. I want to start with the last point that you'd made around clinical care and point of care. And one of the questions from our attendees has centered around um, how do you actually incorporate machine learning to help in AI to help frontline providers use this sort of technology at point of care decision making? Um, when are there concerns of burnout from when there are concerns about burnout from staff and all sorts of digital tools that are being thrown at them constantly, especially at this day and age? How do we fit in machine learning and AI tools?
Well, we have to peel away the tasks that don't add value to patients. I mean, we're burning out because we're doing so much. And when you ask clinicians, do you think everything that you're doing is actually adding value? The answer is going to be unanimously no. The thing is, we continue doing things for historical reasons. To me, the dawn of electronic health record was such a wasted opportunity to start from scratch. All we did was to transform the paper record to a digital format without rethinking what data do we really need. But I think the way to do this is to go back to a clean slate. What do we need to do? What sort of activities truly add value to improving outcomes, and remove everything that does not? So I think the future of medicine will really involve less work in terms of putting in the data. I mean, there will be Siris and Alexas attending rounds. There will be robots. I mean, we are going to have to consent to being recorded during our patient encounters if that means that it's going to make our job easier. And also, for the sake of transparency, you shouldn't be trying to hide what you're doing. You shouldn't be afraid that, oh, I could be litigated. I mean, if our objective is to improve patient outcomes, then to me, being recorded is actually proof that I've done due diligence in making sure that I don't miss anything. But I foresee major changes in the way we practice medicine in the next 5 years. I think there will be more assistive technologies that are going to be there. We're going to be spending less time in front of the computer typing in our notes. I think all of those will be automated. And we're going to be conferring with our assistant robots. Am I seeing the whole picture here? What have other providers in the same situation done? And could you model which one led to the best outcomes so that I can, if I can't really decide at 2 a.m. in the morning whether I should give fluids or increase the vasopressor dose, I could learn something from what other people have done in the same situation.
It's a great response. I want to be a little bit selfish and ask, use the prerogative to ask a question around explainability. This is, received a lot of attention lately, and I think a lot of us grapple with explainability in that there is a camp that says we need to be able to understand what the drivers are of these algorithms. And yet, when you think about the complexity of the human body and the physiological processes, there could be multitudes of interactions and all sorts of nonlinearity in your data that just doesn't quite conform to the way we typically think. How do you strike the balance of explainability with, well, there's too much to try and explain?
No, I'm chuckling, and one of my prepared answer for that question is, um, the next time you see a doctor, can you ask him, or a pharmacist, can you ask him how many of the drugs that we use do we actually know the mechanism of action? Um, Paracetamol or acetaminophen, we actually don't know. All the inhaled anesthetics, we don't know how they work, but we use them because they work. So this, to me, this pushback that, oh, we have to understand something so that we could use it, is kind of bullshit, because a lot of the things that we use, we don't understand how they work. But having said that, there's definitely a growing field in the area of explainability. We have a forthcoming paper that I think is very exciting and really diving into reinforcement learning and being able to interrogate why was this the action that is being um, suggested by the model. And um, I think there will be more of that. Especially reinforcement learning is very difficult for clinicians without understanding how that was built. Like prediction is relatively easy, and even computer vision is easy because you could see which parts of the image were predictors or were drivers of the output of the algorithm. But with reinforcement learning, it's a bit more difficult. So I say stay tuned. I think it's a great paper with Finale Doshi group in terms of really understanding and opening that black box of reinforcement learning.
That's excellent. Okay, so I'm going to ask you a question that I'm sure a lot of people have asked you. I know this has been the topic of many, many discussions, even here at the University of Toronto community. And as we're strategizing around how do we make data more accessible? And I've heard this not only at U of T, but many places around the world that struggle with this issue. And we all point to Mimic saying, how did they do that? Because what a lot of people struggle with, and here's a question, how do you square the need for open data sets similar to what you've built with the need for privacy and use of data in an ethical framework? And a lot of times we get so hung up on the privacy and the ethics considerations that they just stop us from making data sets more available. And I can understand the tension at both ends. How did you do it?
So I think the answer that I give, which is not acceptable to a lot of people, is that to me the status quo is unethical. The way we practice medicine now, where evidence is really there for in the single digits, so the proportion of what we do in the intensive care unit that is based on some good data is, I think, 8% as of the last count. In 92% of the time, we're guessing. Um, uh, Most of the things that we do are based on expert opinion, so eminence-based medicine rather than evidence-based medicine. While all the while, there are these troves and troves of data that are just sitting in servers, and potentially we could learn better. We could individualize treatment decisions um, by unlocking the knowledge that are stored in this data, and it's just there. And to me, the biggest reason why we decided, maybe we didn't realize it before, I mean, the idea of data sharing is just so cool. But to me, we need this because you need to crowdsource the curation part. So if we had not opened Mimic and EICU CRD to the rest of the world, it would take us a century to build the repository. And no clinician would want to sit there. You can't pay anyone just to look at 15,000 entries of epinephrine and figure out which ones are the same, which ones are different. So, but they will do it. Clinicians will do it if they are working on a project that will be published. And they'll be fine in sharing their curation afterwards once the paper is published. And that really allowed the acceleration of research. So people are standing on each other's shoulders, on each other's codes. And you can't do that if you're not going to share the data. So to me, data sharing actually is not enough. What's more important is the sharing of the data curation, which is 90% of machine learning. To us, really, we spend months and months just understanding the data and getting and making sure that you have input from the people who actually work in those ICUs, because you're going to have all this collider bias in your models. And again, if you don't understand the clinical context, you will not even know that this collider biases exist in the data.
Yeah, no, it's a lot for us to take into and have that shift in paradigm of thinking. And I hope that we move faster towards it, because I completely agree. It's almost a responsibility to be able to leverage the data effectively to help patients. Our next question focuses on this issue of the feedback loop issue. The comment is, and the question You spoke of the importance of recalibrating models once deployed. What are the best practices for doing so, especially if the model changes clinical practice? How do you avoid learning that clinical successes are failed model predictions? For example, the model predicts that a patient has high risk of death, the doctor intervenes and saves a life, and then the future data shows that was a wrong prediction.
So we don't have best practices because no one is doing it, unfortunately. One of our papers from last year proposed that there has to be a dedicated department for clinical artificial intelligence. And with that, they have the tripartite mission of operations, research, and training. So I'm not aware of any hospital that would have all the things that I mentioned. So developing, evaluating, piloting, scaling, tracking, continuously monitoring, and recalibrating. So I'm hoping that there will be best practices that will be identified over time. We're still waiting for that first Department of Clinical AI. There are centers out there, but centers are not enough because centers cannot really hire faculty. They don't have residents. So the way that hospitals invested in a Department of Radiology or Department of Laboratory Medicine, there's so much money out there that's being poured into AI, but I think that what we need is a different business model. So we're writing this paper talking about ecosystem as a service. So we think that AI could be software as a service or infrastructure as a service. We think that we could sell and buy algorithms. We think that if we partner with companies with like IBM or Google, that's not enough. But it's not enough. As we know, culture is the biggest obstacle in getting AI into the front lines of care. And this is why we invest our time trying to change that culture, interfacing the clinicians with the engineers and the computer scientists and the social scientists. Because no matter how much money you invest in the technology, if the culture is, if the people are not excited, if the people are not really wanting to change the way they deliver care, it's not going to happen. So this idea of ecosystem as a service, we're hoping to promote. That's exactly what we have been doing really when we go in other parts of the world. We try to connect the hospitals with universities around them. We hook up the students who are interested in machine learning in healthcare. We try to convince the hospital that you have to create something similar to Mimic in your own hospital because the models that you build on Mimic are completely irrelevant to your population. And then we connect them with industry because the industry has the money to invest. And then, of course, you loop in the health ministries because they are the ones who will regulate the use of these algorithms in real life. So it's a long-winded story answer. I'm not sure if I actually answered the question because I forgot the question.
That's great. Yeah, no, we struggle with that whole feedback loop issue, and you're right. I mean, it's not a simple answer. It encompasses so many different things. So thank you for that. And I guess in kind of segueing to that, we get this question a lot from clinicians who are very excited about the space, but don't have a great understanding of what is this machine learning business or this AI thing that people keep talking about. So one of the comments, and there's a few that relate to this, amazing talk, thank you so much. What does this mean for teaching and education of future clinicians and allied health professionals? For example, a need for broader awareness of statistics. How would you advise clinicians to learn more?
I would like to plug that we have edX courses that you could take for free. But the best way to learn this is to jump into a project. Like you could take so many Coursera's or YouTube and watch so many YouTube videos, but it doesn't stick unless you're applying the methods on a question that you're interested in. So so as a clinician, don't be intimidated if you don't understand data science. You have so much domain expertise that is very much needed in this field. And don't underestimate how important domain expertise is. And don't be intimidated by the fact that you're not going to understand a lot of the jargon, because you will pick it up. As clinicians, you're used to being smartest in the room, and you don't like it when you look dumb, and that's totally fine. And I could say the same thing for the computer scientists. Again, they're, I mean, arrogance is on both sides. Like, they don't want to be told that they don't understand the healthcare domain, but they don't. The right questions are very difficult to frame unless you're really providing care at the front lines. So the way to teach this is to bring the students together with different backgrounds. Like, we shouldn't be teaching a machine learning course for doctors. Like, the course that we teach has potpourri of students, and that's how we should teach everything. Like, I don't know why we're not learning medicine alongside nursing students and pharmacy students, because that's how we're doing it in real life in the intensive care unit. But I think the very traditional ways of teaching has to also change. We're writing a paper where we're talking about a different model of introducing this village of mentors as a way to train people. So we have relied on apprenticeship and one-is-to-one mentoring. When you join our group, when I take on a student, they know that they're not just gonna get me; they're gonna get my whole network. And I don't claim that I have the expertise they that that they need to learn this area, but I could connect them. Like, I have mentored students in computer vision. I don't know computer vision, but I know a lot of people who have been doing computer vision for 10 years. But I could provide the clinical expertise, and together you could bring in these different mentors, and they, again, the sum is bigger than the parts themselves. So again, it's a long-winded answer. I forgot the question already, uh, but hopefully I answered the question.
I think that that's great. I think the key message here is just do it, get into it and learn side by side in multidisciplinary groups. No, I want to thank you very much, Dr. Celi. We actually have some very eager students who want to meet with you. So, and I know we're at time, and I don't want to take up more time from the students. So I'd like to thank everyone who attended. I really want to thank very sincerely Dr. Celi for being so gracious with his time and knowledge to share with us today. On closing, I just want to remind those students who are participating in the meet and greet that is happening now to log into the meet and greet Zoom link. And please keep up to date by following us on Twitter and subscribing to our mailing list on our website, tcarum.utoronto.ca. Thank you again so much to everyone, and especially to Dr. Celi for your time and knowledge. And we'll see you again soon in the student break. Thank you.